final session. So welcome, thank you. Appreciate your patience for us starting just a couple minutes late. We had some lots of folks moving in and out and all around. We had to navigate the space for a moment. So I'm going to make this short and sweet because we're starting late. We are delighted to welcome Dr. Brendan Hargett with us for our final closing plenary and look forward to his fabulous presentation. I'm very much looking forward to it. So I'm going to pass it over to Dr. Brendan.
Good morning, late morning. I know some people are making the adjustment to check out, but it's good to be here to talk and share as we talk about dual disorders and co-occurring disorders this morning. And I'm trust that you all have had a good conference over the last couple of days. If nothing else, you got to see the water and enjoy the weather. It looks good, good weather down here. But again, as Sarah said, I'm Brendan Hargett, and I have just a little bit about myself. I've been doing this work for a number of years and worked in a number of different capacities. And one of the things that I've always learned is that this work continues to change and shift and adjust. And for those of us who do this work, we have to continue to shift and adjust with it in order to address the needs of those persons that we serve on a day-to-day basis. And so as I was contemplating in terms of pulling together a topic and a conversation, I wanted to revisit co-occurring disorders. And definitely as we go through this morning and talk and share, and I'll provide some information with you all, definitely you'll begin to identify and how complex the work that we do is on a day-to-day basis. And as we kind of go through and share, and I will involve you all at some point in terms of getting your input and sharing, but it's good to be here. My slides are stuck. But yeah, so it's good to be here. And I trust that as you all have gone to a number of sessions, if nothing else, as you prepare to go back home and go back to your respective places in the state, and there are even some that are outside of the state as well, is that you are going back with some additional information and some different perspectives regarding what we do and how we do, and a very different vantage point. But I'm glad to be here today just to all right, so as we go forward this morning, I want y'all to join me in some polls that I have here. If you'll take out your phones, if you will, and I want you to text this information to 37607, Dr. Brendan, HAR 516. I'm gonna text that to the number 37607. Once you do that, you're going to get an automatic response. And for those of you who are watching us virtually, you can do this as well, so you can participate. Text Dr. Brendan, HAR 516 to the number 37607. And then you should get an automatic response. You join the session. So we'll always try to engage you all and gain your insight here. Dr. Brendan, HAR 516-2-37607. You'll get a response. And we have a number of polls that we'll go through this morning. We'll get your input, and once you type in and text your response, it'll pop up on the screen as we go forward this morning. All right, so thank you all for engaging it. So I have the first question I'm going to ask. I'm always interested to know who's in the room. And so if you will, if you will answer this question, describe your primary training to substance use treatment. If you're mental health, A, substance use, B, et cetera, et cetera. And type in your answers and your responses and get a feel for who's in the room. And I always like to ask this question, particularly when we start talking about co-occurring disorders, because what I've learned is that, our orientation to this work, substance use treatment, may have come from a number of different angles. And so while we may have primarily been trained one way, the hope and the goal is that we begin to expand our perspective to understand. For example, if we were primarily trained in substance use, that we begin to expand our knowledge to where we learn and understand a little bit more about mental health and vice versa. So as we're looking at our poll here, it looks as if majority of the individuals who have responded have been trained primarily in substance use. Good. And so I was always interested because my orientation into substance use, when I started, I was in a master's mental health program at the time. And I was interested in working in the substance use field. So I started doing practicums, internships, working in the substance use world. However, what was happening in the substance use world, definitely there was not a whole lot of orientation to mental health. And so my perspective in the work was a little different because of that. But over the years, as I began to move and do different things, I really began to expand my knowledge and information and realize that the way in which I was primarily trained, I missed some things that may be helpful to those persons who walk through our doors who we're serving. And so as you can see, that the majority of us here have been trained primarily as substance use in terms of our orientation. So thank you for doing that. And so as we begin to move forward, and I always say that landscape, and I use this, the changing landscape, because as we think about, and I'm going to rewind probably 25 years ago, the way in which we approach substance use treatment was very different. Individuals would come into what then was 28-day residential treatment programs. And to some degree, the expectation was that these individuals have gotten what they needed. And they were, as a part of many of our treatment programs at that time, were oriented towards the 12 steps. Individuals would come in, they would, through the treatment process, they would go to group, go to individual, they were advised to identify a sponsor early on in the treatment process. And in that, they were told to stop using, go to meetings, get a sponsor, work the steps, etc. And that's the way in which they were oriented to substance use and recovery. And primarily at that time, the majority of individuals that were working in programs were persons who were in recovery. And they were utilizing their experiences and their knowledge and their ability and their to move into recovery and, as we used to say, get clean to help others who had life controlling issues and challenges. And so as we think about that then, and I'll rewind back, the number of individuals that we worked with at that time, and they were primarily substance use disorders. There was alcohol, or it was cocaine or some other kind of substance. And we didn't really see a lot of other things. Now, mind you, it probably was there. I'm sure it was there, but we weren't skilled enough to identify and know what was going on. So when a person walked through the door, we give them a diagnosis, they would go to treatment, stay there for 28 days, and then they would engage in the recovery process. But now, all of us know that when a person sits across from you, that they come with a complexity of problems. And not only in terms of complicated substance use presentation, but also their mental health. And then sometimes there are some personality disorders, and then there may be some physical health issues as well. And so with that in mind, we recognize and understand that we can no longer be one-dimensional in our training. So while we were primarily trained substance use in this room, many others may have been primarily trained in mental health. However, when we only look through that lens, we miss a number of opportunities to help persons to work through some of their struggles. And so I think that as we understand co-occurring disorders, it's important for us to recognize that the individuals that walk through our doors, they come with this complexity, and we have to understand what I always say is to peel the onion to figure out what's going on. So how do we define co-occurring disorders? Co-occurring is considered persons who have more than one mental disorder as well as more than one substance use disorder. And so when we talk about that, it's a matter of, and I'll talk about diagnosis in a little bit, but really identifying that there's something going on that meets some of the criteria, and as it says here, it's to be clinically significant in terms of impairments, and it begins to affect individuals cognitively, behaviorally, as well as some psychological symptoms. So when a person walks through our doors, and when we start thinking co-occurring disorders, we're looking at them to say, okay, there is probably a diagnosable mental health condition. There's also a diagnosable substance use disorder. Now, when they walk through the door, we really don't know what we're looking at, even though the presentation may seem and appear to be some mental health symptoms, it may be some substance use symptoms. And so it's really still very complex for us to figure out at that point. But when we use this term, and I think that even now we've moved to co-occurring disorders, years ago, we had a number of different terms that we used to identify persons who fit this category. There were mentally ill chemical abusers. We've heard the term dual diagnosis. We've heard the term chemical abuse, mentally ill, a number of terms that we use throughout the years to identify persons who have this complexity when they walk through our doors. So we have now, over the past 20 plus years, we're now using the term co-occurring disorders. And so this is what we mean when we talk about it. And as you can see from this graphic here, is that the overlap. So we have mental health disorders, we have substance use disorders, but the co-occurring are those who have a combination of both. Now, I'll talk a little bit later about substance-induced mood disorders or mental health disorders, and how we also can recognize that substance use can cause and create some other mental health symptoms. And so again, that's all a part of that co-occurring world as we move forward here. So another poll for you all: what are some of the challenges treating persons with co-occurring disorders? If you'll type that in on your phone, and let's see what your thoughts are around that. And I have my own ideas, and you'll hear some of those in a minute, but I want to hear from you all. What are the challenges treating persons with co-occurring disorders? Now, I'm making an assumption that all of us in the room are treating persons with co-occurring disorders, and we are, whether we know it or not. A number of our persons that walk through the doors, they have some complex, as I said, that complex presentation. Resources, community, psychiatric, funding, psychiatric trust, manipulation, knowledge, diagnosing, kind of a word blob, insurance, mental health symptoms support, COVID, ambivalence, pathologizing, diagnosing. So yeah, there are some challenges to treating this population, and we identify them and we see them here. And I think that as we recognize that, hey, this is very, very difficult to treat. And I think that there are some things that we want to take into consideration as we begin to work with persons with co-occurring disorders, which is what we're going to talk about today. As FYI, for those of you who joined the Hoover app for the conference, all of the presentations and slides, there are 3 different documents that are on the Hoover app where you can access my slides here, as well as some other additional information that may be helpful to you as you go through. So you'll have that. So thank you for sharing that poll. So what do we know about co-occurring disorders? And this information comes from the National Institute of Drug Abuse, that we have roughly 7.7 million adults who have co-occurring disorders, okay? And so when we think about that 7 million, we go on 20.3 million adults with the substance disorders also had a mental illness. 42.1 million adults with mental illness also had a substance use disorder. So when we start talking about co-occurring disorders, we're concerned about that 38% and that 18%, and really being able to address their needs. So as we think about it, we know that it's prevalent. Okay, persons do have legitimate diagnosable co-occurring disorders. And so it's out there. And so what we want to do as a field is to be more skilled at identifying, but also being more skilled at treating those individuals, because I like to think of it this way, is that when someone is mistreated and not treated for what's going on, that the likelihood of them to relapse, and return to use is very high. And so I think that as we can identify those persons when they walk through the door, and do a better job of identifying it. As I said, sometimes it's very complex. And one of the biggest challenges that I have with our systems is that we're expected to make these decisions about what's going on within that first session, which is highly impossible. And so I think that, again, we know that individuals out there, it happens, and we know they're there. So what do we know as regarding some of the facts? Is that not everyone with co-occurring disorders are getting the treatment that they need. Over almost 53% of those with co-occurring conditions did not receive mental health or substance use treatment. So when you think about that, and I think there are probably many ideas about why those individuals did not get the treatment that they needed, but they are out there. And so we want to be very much aware that there are persons who are walking around in our communities who need the help, who haven't gotten neither of those services. 35% of those with co-occurring conditions only receive mental health care. And a lot of that depends on where individuals walk through the door. So if I'm working in a hospital setting, or say if I'm working in a mental health agency, the person walks through the door, and going back to my primary orientation, if I've been trained as a mental health professional, then I'm going to look through that mental health lens. And it's very likely that I may give a diagnosis and begin a treatment plan for mental health. But did we really assess and screen for the substance use, and vice versa? And a lot of times what happens is that we ask those questions. If I'm doing a substance use assessment, have you ever been treated for any kind of depression, anxiety, or other mental health conditions? Now, whether they've been treated or not doesn't mean that they don't have it, but we have to be skilled in knowing what questions to ask to really assess, to determine if there is a substance use disorder or mental health disorder. 9% of those with co-occurring conditions receive both mental health care and substance use treatment. And that's the number we want to improve. That's the number we want to pay attention to, because again, that means that these other individuals aren't getting what they need. And as it relates to substance use, the likelihood of them to relapse is very high, because they are not getting what they need. And a lot of that starts with when they walk through our doors, and we sit down with them in our agencies, what we do and how we approach that process. 3.9% of those with co-occurring conditions receive substance use treatment only. And so again, individuals are getting something, and some will say, well, something is better than nothing. Well, there may be some truth to that. However, if we're not doing the right thing, it's not as effective. And so we want to be more effective in terms of what we do here. So I have a couple case studies I want to share, and I had two, but I want y'all to take a look at Sharon right quick. So take about 2 minutes and read through this scenario, and then I'm gonna poll you all to see what you would do with Sharon. And I'll just kind of briefly talk about Sharon. She's a 41-year-old mother of 3 who's having some significant symptoms of nervousness, irritable, no appetite, is not enjoying life. She is drinking about 3 to 4 glasses of wine a night, and she's been doing that for years. After she had her first child, she had some mood disturbances while she was in the hospital, and she's been divorced. She has twin daughters, 16-year-old son who lives with the father. She shows up at your door. What are you going to do with her? Take a minute to read through that so you can look at the details, but that's her synopsis. Is Sharon. And there are no right or wrong answers. Sharon, 41-year-old, 3 children, set of twins and a son. Pay attention to her symptoms: nervous, irritable, loss of feeling in life, no appetite. She's drinking a lot, stays home, drinks up to 3 bottles of wine a day. Blackouts, can't remember her father, alcoholism, but stop drinking. So Sharon walks through your door. She sits down in front of you and she presents this to you. What are you going to do with Sharon? Where would you start? Detox. Okay. Ask her, what does she need? Assess for depression. Okay. Assessment. So in the assessment, what are you looking for? Assess for mental health, assess for safety, mental health assessment. Okay. So good. So Sharon, look, trauma, what is that? And those person who put that in there, we would always raise our antenna to if there's any kind of trauma in her life. But again, we're gathering information. And so as we walk through this talk here, I'm going to kind of highlight some things that we need to think about before we begin working with Sharon. And this is good. How'd you get here? What's your biggest challenge? And you can see some of the responses and answers there as we move forward. But very, very complex in presentation. Been drinking for a period of time, some symptoms that are there, and some other things. And there's a few, perhaps some family problems as well that's happening with Sharon. So our approach to her will be very different, but again, we do have a starting place. Thank you all for doing that. All right, so what do we need to take into consideration before we start working with Sharon? And I think that it's important to understand that traditionally, our approach in working with persons with co-occurring disorders it's been interesting to say the least, but however, it hasn't been the most effective. Now, traditionally, what would happen is that individuals are not eligible for, mental health treatment until they have gotten a substance use treatment. Many years ago, in my county, where at the time I was employed at the time by a mental health center to develop an intensive outpatient program for persons with co-occurring disorders. Walk through the door, they say, here's a budget, develop a program, figure out how to make it happen, because persons in our communities are showing up at our mental health center intoxicated. And what they would do is to say, well, because you're intoxicated, you need to go down the street to the substance use facility. And they would go across the street to the substance use facility. They would take them through detox. And through the process of detox, that person would start hearing voices And then they would say, tell the voice not to say anything else. We're gonna send you back to the mental health center. Well, on the way back to the mental health center, they stopped by the 7-Eleven, take a drink, end up out on the street, and these individuals were bouncing back and forth. And that was a problem in the county. So they said, hey, we need to figure out how we can address that. Now, as I said earlier, a part of that was because of the lens in which individuals were looking from. And that sequential approach was that fact that, well, we can't treat mental health until you have gotten the substance use addressed. And while they're getting treatment for substance use, well, all these mental health symptoms, and we can't deal with that. So we need to do this, and then you go across the street, and individuals tend to bounce around. So the disadvantages of that is the fact that, there is, when one disorder is not treated, it gets worse. And again, it makes it very, very difficult to stabilize that individual to figure out what's happening. There's sometimes a lack of agreement as to which disorder should be treated first. And there are many individuals who would say that, well, you have to deal with this first in order to deal with that. But if someone has co-occurring disorders, then you treat the symptoms of what walks through the door. And so often we try to separate out the symptoms, but they're happening in the same person at the same time. And we cannot always just separate them out. And one of the arguments I had, or disagreements I had with our medical director at that time, because the rule was that if you want, in order to get psychiatric help or mental health treatment or medication for those who need it, you have to be absent or substance free for 6 weeks before we can ever prescribe. Well, if I have a legitimate co-occurring mental health disorder, and the likelihood of me maintaining for 6 weeks is not likely going to happen. And what happens, individuals who have significant mental health disorders, what tends to happen is that they start self-medicating by using substances. And so again, that sequential approach is not very effective. The parallel approach, disorders are treated simultaneously, but you have different people from different agencies doing it. So on Tuesday and Thursday, you come to my group. On Monday and Wednesday, you go down the street. Okay, you get your mental health on Monday and Wednesdays, substance use on Tuesday and Thursday. And so individuals tend to move forward. And so some of the disadvantages of that is that the providers fail to communicate. And a lot of times, depending on the lens in which either looks through the individual and the symptom presentation, it may be, the information may be conflictual with what the other person is telling them. And so what happens is that client possibly will get lost, gets confused, because you're telling me to do this and that person telling me don't do that. And so how am I supposed to respond? So there's a lack of coordination. And a lot of times the integration falls on the client. And again, if I'm thinking and hearing from two different people, two different messages, then it's very difficult for me to know what I'm supposed to do. A lot of times providers lack the common knowledge, common language and treatment methodology, which creates problems, and individuals tend to slip through the cracks. So sequential, parallel hasn't always worked. And I think particularly when individuals are not communicating. So how do we get to move towards integrated treatment? And that's where we want to go. So first of all, as we screen, and then as we talked about Sharon earlier, someone says, well, we need to do a mental health assessment. We're going to integrate our screening and our assessment, which means that those of us who are doing this work, we have to enhance our skill and our ability to see through this integrated lens. So whether that's, and in the handout, there are a number of recommended screening and assessment instruments that may be helpful to think about as you begin to move forward to start this integration. Referring persons to co-occurring recovery groups. And I think that our 12-step community, and there are now a number of different alternative 12-step groups, but years ago it was AA or NA. And what would happen at that time, and I'm thinking when I first started, is that individuals in certain groups would tell persons not to take any medication, et cetera, you need to just stop using. But sometimes these individuals have legitimate mental health issues. So we're talking about having support systems among individuals who understand the co-occurring disorders and how that plays out. So whether that, and some of our communities have those and some of our communities don't. I know some health systems and communities have, whether it's a depression group or an anxiety group or things like that, that can be a level of support for persons who have co-occurring disorders if they're not integrated in your community. Motivation enhancement, we know that works, and most of us in this room probably have some training exposure to that. We have to begin to think about medication and how medications can be used. All medications are not mood altering. And I think that was some of that mentality around NA members telling persons not to use any substances because the assumption was is that that is a mood altering substance versus this is a medication that's going to help regulate my thought process and help me to deal with depression or anxiety. So treatment interventions are combined, and the fact that we're trying to address both disorders, and not only both disorders, but the problems that are associated with that. And as we talked about trauma, Sharon, earlier, someone mentioned trauma and the fact that we have to be able to integrate that. So ultimately, when we think about it, we are no longer just substance use professionals. We're no longer just mental health professionals. I like to use the term, I am a behavioral health treatment provider. And I think that as we begin to think differently about the approach to our work, because when that individual walks through the door, we at least have to know a little bit about everything. The program that I mentioned earlier, I was fortunate to able to hire a psychiatrist with specific addiction medicine, and also had a nurse practitioner who was a mental health nurse on staff, in addition to substance use, mental health, co-occurring professionals, and that helped us to move individuals through the program in a very significant way. So having those resources around you when I may not be skilled enough in terms of medicine and understanding all the complexities, but I have a doc that I can refer to who has that sensitivity, who's looking at this through an integrated lens, which is very important. So that's what we're trying to do, is to integrate the treatment process along the way. And these are just some suggestions and recommendations to do that. So another poll, what do you think are the barriers to providing integrated treatment for co-occurring disorders? What are some of the barriers to providing integrated treatment? Funding. I'll talk more about that. Licensure, education, insurance, funding, training. And as you all are responding to this, one of the challenges is, I think, a couple of things. The training part of it, and I do some adjunct faculty work, and one of the things that in a mental health master's mental health program, and one of the things that I constantly share with my students who are being trained primarily in mental health is that we have to become behavioral health professionals. We can no longer afford to be one-dimensional. And so I'm encouraging them to get the substance use background, get the mental health background, vice versa, whichever one that they have. So what happens, and this is something, and this is for those of you who are in the policy work and pushing, and even as an organization, AP&C, we have to push and change the systems that are not supportive, if you will, of what's happening to persons who walk through the door. And I say that in this way, is that if you are, and I'm talking about in our state system, if you are a licensed clinical addiction specialist and someone walks through the door and that's your credential and they have mental health issues, the way in which you treat that is very different. How you diagnose, how you set that up, and vice versa. Same thing with mental health. And so I know that there are a number of individuals now who are being duly licensed, which is a part of it, but I think that we have to move even globally more so to where individuals not only are credentialed to understand mental health and substance use, but also being able to address the issues. Now, mind you, we have an ethical responsibility not to move outside of our scope, but we have to expand our scope of experience and expertise. And as professionals, substance use professionals, we should pursue other means of gathering information to understand the person that walks through our door. Over the past probably 5, 6, 7 years, trauma-informed work, trauma-informed treatment has become the buzzword of mental health and substance use. And most of us in the room intentionally went and got some level of training in trauma so that we can understand how trauma crosses with substance use and mental health so that we can better help that person. So I think that as we begin to look at our systems, we have to challenge our traditional way of doing things and how we've done it, and is it really effective for the populations that walk through our doors? And so again, these are some of the challenges that we have in terms of our training, our lens, our exposure, and I think we still deal. I saw a session earlier this week on stigma. We are still dealing with the stigma of mental health and the stigma of substance use. And so as professionals, we have to fight that on an ongoing basis. And for even some of the substance use professionals, not anyone in this room, but others outside of the room, they stigmatize the person when they walk through the door and they have a mental health disorder. And we tend to, say, make terms and say things about individuals that is very insensitive. And some of that is because we have not been informed, or we're not enlightened, or we have assumptions that we've made about them, and vice versa. There are mental health professionals who do the same thing for a person who walks through with a substance use issue. And so we have to begin to work to tear that down, because I think that the more we can eliminate the stigma, it's going to help us to integrate our legislation, our practices, even our practice boards and our licensing boards, to really begin to think about what we can do in order to better treat the individuals that walk through our doors. Because it's a very, very complicated presentation that we get. So these are the principles of effective treatment. I'm not going to go through all of these. I'm going to just hit these. And this came from NIDA. It started back in 1999. NIDA put out the 10 principles of effective treatment. They've upgraded it, updated it, and this is what we have as of 2018. But the first one is the one that I think is most important, is relevant to what we're here. And it used to be no wrong door to treatment, but now it's no single treatment is appropriate for everyone. So wherever someone walks through the door, we want to build and create the capacity to, even if we don't have the full capacity to treat the individual in terms of our continuum of care, if we can at least identify what's happening, then we can try to connect them with the right sources and resources until we are equipped and prepared to manage this individual as they walk through the door. So treatment needs to be readily available and all of the other things that come with that. And so you all can look at that at your leisure. And I think that, we have to realize that, the way in which we did things, and this was in changing landscape 25 years ago, is not as effective. And the fact that even what we did 5 years ago has been changed and shifted. And so this field is constantly shifting and changing, and we have to be up and prepared. And one of the things that I've tried to do in terms of bridging the research to practice, and some of the work that I've done is try to make sure that as we do this work on a day-to-day basis, we have what we know is to be effective, and so that we can help individuals. So those are some of the principles. So before we begin to work with an individual with a dual disorder, a co-occurring disorder, we must understand and recognize that alcohol and drug use mimics psychiatric disorders. So Sharon, as an example, comes in, she's drinking 3 to 4 bottles of wine over the weekend, and a lot of wine, right? So we have to understand now what she's drinking, she's using alcohol. How can that cause her to experience certain psychiatric disorders? So when you start thinking about the amount of alcohol she's drinking, when you start thinking about in the context of her anxiety, there's some depression symptoms there. She is really based on the amount. So it's possible, right, that her substance use could be causing some of these symptoms, right? Everybody agree to that? Yeah, we agree to that. So we do know that alcohol, acute and chronic alcohol and drug use provokes and worsens psychiatric disorders. So if Sharon already has, say, for example, an anxiety disorder, and she's using the amount of alcohol that she's using, it can make those symptoms even worse, right? And so I think that, so that makes it very complicated for us to try to figure out what's going on with Sharon. Alcohol and drug use mask psychiatric symptoms. I talked earlier about individuals who are self-medicating. It's the fact that, well, I'm having something going on, but every time I drink, it goes away. However, it may not go away for a long period of time, it still goes away. And so we have to understand and that gets back, when we start talking about diagnosing, if someone comes in and they have a recent history of using, then I have to understand that, well, there may be some other things going on that I may not be able to identify right away. So for me to solely just give a diagnosis of substance use when I know that the use, depending on what they're using, can cover those symptoms of a psychiatric disorder. So that's why we don't want to jump too quick, too soon to making a diagnosis, right? And so again, we know that. Next, we have alcohol and drug withdrawal mimic psychiatric syndrome. One of the things that was really common that I saw years ago working in the mental health centers, that individuals will come through our emergency department, and they would have this erratic, extreme behavior that mimic or look like symptoms of bipolar disorder. The agitation and just all of the symptoms were there. And a lot of times, if we didn't assess and ask the right questions, we didn't understand and know that, oh, well, they were just using cocaine. And they've used cocaine in the last couple of days, so that what looks to be like a manic situation may be intoxication or maybe the after effects of using a particular substance. And so we have to understand that, and the fact that if there's a legitimate bipolar disorder and they're using cocaine, and it goes to the other extreme. So how and what a person is using, we have to really understand that. And sometimes they're not, our clients aren't always honest with us, right? So we have access to drug screens and to gather information as what we can to really see what's going on and the complexity of what we're dealing with. And now, as I mentioned earlier, persons have one or more substance use disorder, co-occurring disorders. Persons can legitimately be cocaine use disorder, severe, as well as, you name it, some of the other symptoms that are there. Psychiatric and substance use disorders can coexist, and that's where we're trying to get to, is recognizing that this can be legitimate, and that is a co-occurring disorder. And lastly, psychiatric behaviors mimic alcohol and drug-related behaviors, going back to what I said about bipolar. It's the fact that, well, someone has bipolar, it looks like you're high on cocaine, depending on where the person and where they are. So these are some things that we have to take in consideration before we start working with Sharon. Before we start treating her, we have to take this into consideration, and so that we don't make the wrong decision about what we do with her and what we're going to do with her in that process. So that's the knowledge and the pre-treatment information that we need. Okay. All right. So let's talk about diagnosing. And one of the things that we've learned, we put a lot of emphasis on diagnosing in this field, in this work. And a lot of that is connected to funding, because if they don't get this diagnosis, they can't get this level of treatment. And nobody in this room, but other professionals sometimes make the decision to give a diagnosis based on where the funding is coming from. Not looking at anybody in the room. But that does happen. And so when we start thinking about diagnosing, if the diagnosis is wrong, then everything else is wrong. In the medical world now, if you go in and you're having, say, surgery on your left shoulder, what they're doing now, and some doctors, they're actually making sure they mark it with an X or put something to notify the surgeon that this is the arm that needs to be operated on. So just think, if this person goes into surgery and the diagnosis is wrong and they operate on the wrong shoulder. So what happens with that? That the problem still exists, right? And therefore they've been mistreated, but then the problem hasn't been alleviated. So it's important for us to get the diagnosis right on the front end, but we have to change the way in which we diagnose, particularly when we start talking about current disorder. And this is where I talked about this system piece, because our system tell us that in this first session, you have 50 minutes, 60 minutes to do a substance use assessment. And at the end of the assessment, you need to be able to give a diagnosis, write your note, send it to medical records. Now it goes to billing and it goes around. But what if I got the diagnosis wrong? And the treatment starts, but I am now mistreating the individual. So diagnosis is important, and it's only important to give us a frame of reference of symptom presentation to know what and how to target our interventions in our treatment plan, not just payment. So it's about setting up the treatment plan along the way. So question for you. This is a true or false question. A is true, B is false. A primary diagnosis is essential in treatment for co-occurring disorder. True or false? I'm just changing the answers. A primary diagnosis is essential in treatment for co-occurring disorders. 82% says false, 17% of those who responded are saying true, and some of you are still back and forth, and that's okay. And my point is, we don't want to put a lot of emphasis on diagnosis, but it gives us a frame of reference. And so in terms of the treatment, because sometimes you're not going to know in that not only the first session, but sometimes if the person's actually engaged in treatment, it takes a while for you to really understand what's going on. And so again, how we approach that has to be very different. Another question for you. How confident are you diagnosing co-occurring disorders? Highly confident, moderately confident, somewhat, or not confident? And if you are a substance use professional, based on the first slide we answered, how did you get to, for those of you who are highly confident and substance use professional, how did you get to that highly confident perspective? Think about it in that way. So moderately confident in diagnosing co-occurring disorders. And one of the things that, I say diagnosing, I'm thinking ballpark in terms of there's some depression, there's some anxiety, there are some psychotic disorders that are there, something is going on, but I'm not quite sure yet. So in the ballpark, a lot of us probably can say something's going on, but going back to that pre-treatment knowledge, but I don't know if it's caused by the substance or this happened, there's some trauma, there's some grief. So it makes it very complex. And what we want to do is hit it in the ballpark. And I will always tell my clinicians is that we err on the side of less. So if I see someone early on, and I would give our clinicians at least 2 hours to do the initial assessment. And after that, if we're uncertain, if I'm not sure if this is a legitimate mood disorder, but I see symptoms of it, but I want to at least write it down so that it's in our view, so that we can continue to assess and look at it. I may go for and something just happened in their life, I may say, well, let's look at, some type of adjustment disorder with depressed mood before we move into any kind of extreme, what I call extreme, the higher level of diagnosis. So most people are confident in doing that, and some were still not confident. And for those who are not confident and somewhat confident, the hope and the goal is that we build our knowledge and we gather the information that can help us to be more confident. And when push comes to shove, we always can collaborate with other professionals who have more knowledge and information. That seems to help a lot of individuals because, as we talked earlier, the complexity of the problems of persons that walk through our door, it's not so easy to just make a determination about what's happening with them along the way. So just put this here, just FYI, you all know this in terms of the criteria, and in one of your handouts, and all of that is spelled out, particularly what the criteria may be. So we're diagnosing substance use disorders, mild, moderate, severe, and of course the DSM-5 changed from abuse and dependence to mild, moderate, and severe, and that gives us some classification. Also, what went away with the DSM-5, you all know this, is that we no longer have the polysubstance diagnosis. However, we're looking at each substance independently and trying to determine how mild, moderate, and severe. Now, some of that, going back to the complexity, is that, a person may use another substance more in the absence of a substance that he or she may prefer. But still, does it meet mild, moderate, or severe? And we have to look at that in the context. And so knowledge-wise, we need to understand something about the symptoms that are associated with these various psychiatric disorders. And I think that what we do have when we think about schizophrenia and psychotic disorders, we're talking about individuals who have a disturbance of thought, that some delusions, some hallucinations, and some other things that are associated with that. Pre-treatment knowledge, we know that certain substances, or a person is in DTs or they're going through severe alcohol withdrawal, they can mimic some of these symptoms, right? And so, and we also know that there are substance-induced all of this. And so that, again, makes it very complex in order to treat and address co-occurring disorder. So we don't want to jump, again, quickly to diagnosing someone along the way. So bipolar and related disorders, we're talking about disturbance of mood, and I talked about the extremes, and that presentation, person may become depressed for a few days, and after a while, they're up, they'll paint their house, my house, everybody else's house, and they'll go for 3 or 4 days that way, and then there's a crash. Well, if I'm using cocaine, then that may look the same way, but we have to understand that there are some disturbance of mood in terms of that elevation of mood. Depressive disorders, and depression can look very different. We know, I think that when we think depression, we think about someone who is sad, suicidal, and just been depressed for a number of days. But I worked with someone years ago, and the psychiatrist helped me understand she called it an agitated depression. It was an irritability, it was an angry, it was an aggressive kind of presentation. And some of us will look at that as just more behavioral, but in this situation, it was a very different presentation of depression. So we have to understand that anxiety, and particularly after what happened in a session earlier about COVID and all the things that have happened over the past couple of years, the anxiety scale has risen significantly. There are a lot of people who have probably more, not necessarily the last 2 years, but probably over the last 8-10 years, anxiety has been a common presentation among individuals walking through our doors. And I'm talking about legitimate anxiety where individuals, whether it's social phobia or a number of things that are going on with them. So we want to understand what are some of those symptoms, what does it present like, and being able to know what happens where the person is having panic attacks, or the person is having, don't want to be around people, they're locking themselves away, or just having some of the symptoms that are associated with that. Of course, trauma, stress-related disorders, DSM-5 broke that out, and this is where we find PTSD and other types of trauma diagnoses. We have to understand that. Anyone here work with adolescents? Okay, so adolescents in terms of trauma, as well as some of the other presentations that are associated with trauma. We've now put some labels onto it, if you will. Don't like labels, but at least gives us some defining criteria of what's happening, which should inform us of how to treat them along the way. And personality disorders, I put that there And there was someone that I used to work with who thought that everyone with a substance use disorder, woman, had a personality disorder because of the way they present. Of course, that's not accurate, that's not true, but that was the lens that she looked at. You know, everyone was manipulative. Well, that comes with substance use. You know, if I'm abusing a substance, I may be manipulative. So that doesn't necessarily mean that it's a diagnosis or symptoms of a personality disorder, particularly I'm thinking about borderline personality disorder. But again, those was, so we have to rethink and continue to retune what we're seeing. So when we find ourselves getting stuck with clients to where there's no progress at all, then, you know, years ago, what would happen, and this has always amazed me, is individuals would be engaged in treatment, but there's no progress. The approach to them is to send them home because you're not ready yet. You haven't hit bottom. These are the language that we use, unfortunately. So it's not the individual, it's the treatment. It's the planning process. And so we as professionals have to think differently. And when we're running into all these barriers and approaches, when we're trying to do what we've always done, then we need to rethink what we're doing. And I'm hoping that as you, particularly around co-occurring disorders, that you begin to think differently about the person who sits across from you so that we can better engage them along the way. We talk about motivation interviewing all the time. We're doing in motivation enhancement, motivation interviewing, but our systems sometimes don't allow us to work with them long enough to get them to that point of being ready at the action stage of treatment. And so sometimes that's a barrier. And if you think about it, you know, and if a person has been using for 15, 20 years, and now we're trying to encourage them through motivation interviewing to get to a point to consider the effects of on their lives and what happened, it's not going to happen in 3 or 4 sessions. And so we have to be able to engage them in that process. So understanding around psychiatric disorders, understanding around substance use disorders is the somewhat of a basic knowledge and information that we should have. So when we start talking about trauma, and that came up as we started thinking about Sharon, and maybe something else is going on around her. Why would we assume and think that Sharon may have been exposed to trauma? Well, some of the data and that we know around women and trauma, particularly, may give us some insight. Now, that doesn't mean everyone that walks through our doors have trauma histories, but we want to be able to assess that, understand that, and try to address that as best we can. And so these are just some data to take into consideration, particularly the second bullet. 25 to 7% of people who have survived abusive or violent traumatic experiences report problematic alcohol use. So we think about Sharon and we look at the extremes, that might be true, so we want to explore it. And we have to learn how to interview and ask the questions to understand if there's a trauma history. I mean, it used to be just a question on the assessment, have you ever been abused? Have you ever been this? And that in itself, we've become more advanced in our way of asking questions around to understand trauma. And sometimes a person may not, if the assessment and the interviewing is done a certain way, you can draw the conclusion of trauma from what's happening from the story and know that there's a trauma history without ever having to ask them that. And so what we do then in the way in which we articulate it, we can confirm it by how we summarize that and explore that with them. And that's a gift and that's an art that we have to develop as clinicians and as those who are doing assessments to try to figure out what's happening. And let me pause here and I'll say this because this happened to me and I hope it didn't happen to you all. But as I was training substance use world, one of the first responsibilities of jobs that I had is they stuck me on the front end to do assessments. Brand new, still learning, still growing. And because we thought it to be just fill out the form. Just ask the questions and fill out the form. And for those persons who are doing assessments, should be your most skilled clinicians. When you think about this complexity that I just talked about, substance use disorder, psychiatric disorder, trauma histories, I don't want to put someone who on the front end who just walked out of school or who has limited experience understanding the complexity of addiction. And so that's where that skill comes in. How do I ask Sharon and assess and understand what's going on and know that there's a trauma history? So it's prevalent. Women who are exposed to traumatic events show an especially increased risk for alcohol use disorder. We're talking about Sharon. Men and women who've experienced sexual abuse have higher overall rates of alcohol and other substance use disorders. So when we start talking about an experience, looking at the different types of trauma, the different types of substance use, and there's a lot of research out there, there's connections between certain types of trauma history, certain types of trauma exposure to certain substances. And so as we understand that, then that better helps us to ask and screen and gather information as we move forward. So trauma and substance use disorders go hand in hand. And I think that everyone who has trauma history is not necessarily have post-traumatic stress disorder. And there's a continuum of trauma and stress-related disorders that we have to take into consideration. And some persons who may have been exposed to trauma and experienced the trauma, and they may be experiencing significant levels of anxiety around certain things, but it may not be a trauma diagnosis. And so we have to be very cautious about that. And then some people, you know, when they get triggered around their trauma, they may become depressed. And so we have to understand that there's a complexity there. You all probably have seen this, the Adverse Child Experiences Study report. And I say this because, and I want to put this here, is as we begin to work with individuals and as we gather their histories, and that's why I say you can explain and see trauma, when you start recognizing that this person was exposed to physical abuse a number of times as a child, the mother was treated violently, et cetera, we already can identify that, yes, this person has some level of trauma. We can confirm it based on the information that we gather. And the science behind this lets us know that the more ACEs or the more yeses that a person may have to this trauma history, it ties to longevity and shorter life. And so as we identify it, we want to be able to at least softly, carefully create an atmosphere or a clinical environment to where it's okay for that person to engage and manage it. That's where the trauma-informed comes in. As we learn and we're trauma-informed practices, knowing how to handle that, knowing what to do with it, so that we can create a safe place. Because a number of individuals that walk through our doors with co-occurring disorders, they have with trauma histories, no one has ever really asked them about it. No one has really ever explored it. And so we have to be cautious about opening that door. We can know it and be aware of it, but if you don't have the skill and the training to know what to do with it, then we can connect them to someone, hopefully within our organization, who is more skilled at that. But we at least want to affirm for that person that this is real. I'm sorry that happened to you. We're here to support you in whatever way we can. So that's why I put that there. And this is the chart that goes with that, as I was talking about how it begins to impact other parts of a person's life along the way. So trauma is important to understand. It's important to address. So when we think about up to what we've talked about so far, assessing, or at least diagnosing, identifying the presentation, substance use disorder, psychiatric disorder, trauma, etc. This is already complex, right? Now let's go back to Sharon. Sharon, 41-year-old woman, presents with this history, and we start exploring through this the likelihood of us really always say putting the puzzle together, because we get pieces, right? We get pieces of the puzzle on the assessment, The first individual session, we get another piece, and we may not get another piece until 3 weeks down the road in group to where it's like, oh, that's the big piece in the middle that we're missing to this puzzle, and we put it there. So we as clinicians, we're trying to put the puzzle together. And depending on the severity of a substance use disorder, sometimes the person sitting across from us, they don't know all the pieces that should be in the puzzle. So they can't put it together. We start asking questions about history and this and that, you know, depending on, again, the severity, they may not be able to really put it together in a way that you can comprehend it. But what we do know, based on our experiences in working with persons with substance use disorders, co-occurring disorders, there are some things that are consistent throughout persons with substance use disorders or co-occurring disorders. So screening and assessment. Talked earlier about the integrated screening, the integrated assessment, and I told you this recommendation is that your most skilled clinician is the one who's doing the screenings and the assessment. When a person walks through the door, that's where it begins, because we don't want to get the diagnosis wrong. And so as we begin to work with individuals, and these are some of those assessment instruments that that are out there that tend to highlight some of the co-occurring disorders. One that I am particularly familiar with, that I always talk about it, is the GAIN, the Global Appraisal of Individual Needs, which is a very comprehensive substance use assessment. Takes a while to do it. It's self-report, but it has what I call a lie scale in it, to where it highlights the inconsistencies, particularly when you do it in the electronic format. I was one of the trained facilitators of this assessment, and love it because when you do it on a computer, say for example, if you ask someone, one of the questions is, how many days have you gone without using substances in the last 90 days? And they tell you 10. And then you ask them another question, how many days have you used alcohol in the last 90 days? If they don't say 80 and they give you another number, you get this pop-up on the screen that says there's an inconsistency in their report. And therefore you can go back and clarify with them what's happening. And then once you are done with the assessment, it gives you a comprehensive summary of everything that this person has said. And it assesses mental health, it looks at trauma, it looks at recovery, and it's consistent with the ASAM criteria. And you have pretty much, based on what they say, goals, and you have a treatment plan already at the end of the assessment. Very comprehensive and very ideal with dual disorders. I was working with students at a university and doing co-occurring assessments, and would use the GAIN assessment, and it gave me so much information about the student, and it looks at education, looks at all of that. And what it does is that the ultimate goal of the assessment is to determine how these other areas in their life may be contributing to the substance use. So if they have a significant mental health diagnosis, it helps you to diagnose it because it's counting the symptoms and it asks the questions for you along the way. And if someone doesn't answer these questions, it skips and go on. But anyway, I get excited about the GAIN, but that's one of the ones that is there. But identifying what works for you. Now I know we have, use our comprehensive clinical assessments, our diagnostic assessments, or what have you. And the only thing that I would always encourage, and the clinical interview is always good, but it's only as good as the questions that are asked. And the good thing about some of these assessments, instruments, as they have been tested and researched, is that it gives you asks you certain kinds of things, and it's going to give you certain measures as it relates to some of the diagnosis, as relates to the screening and the assessment. So these are just some of those instruments. So what's our approach? How do we begin the assessment process? I would always tell clinicians, the goal of your first session is to get a second session. And that starts with how you engage the person who's coming to see you. Now we have our own style, our own way of doing that. And sometimes you think about it. If I come to you for an assessment, I've never met you before in my life, but I sit across from you, and the first question you ask me is why are you here? You know, somebody told me to come over to see you. Okay, now we have to go in, well, I need to know you in order for me to really start opening up. And so that engagement process, that's why I said I give our clinicians 2 hours, because I need to know you, know something about you. I need to share a little bit about myself. That don't mean we're going into too much disclosure, but we need to engage this person. So what does that look like? So-and-so, nice to meet you. I'm such and such. I'm here to do this. This is what we do. Tell a little bit about yourself. And usually for persons who've been in multiple settings, multiple systems over time, the first thing they start down is I'm using this. Okay, we'll get to that, but I want to know about you. Tell me, what are your hobbies? What are your interests? Well, I used to do this before I started drinking. Okay, but let me learn about you. And then you begin to engage them and talk about what this process is, what I'm going to be doing here today, ask you some questions. Some of them may be a little, sensitive for you. Don't feel obligated to answer or respond. You have that option, but I'm here to support you and help you to identify how we can best support you and help you. And so that engagement process is important. And most of us in our graduate programs, we learn about establishing a rapport and relationship, but somehow, because our system has said, you got 50 minutes to make this happen, because there's somebody else waiting on you to do this assessment. And don't dare get behind and overlap. Now your leadership in some places are on you because you're taking too long to do the assessment. But we have to engage that individual. And so that process takes time. If there are other persons that they want involved in their process, identify them, get appropriate consents, talk to those individuals to learn about what they know, what they've seen. And then you can utilize that in a way to engage the client even further. Well, I talked to your significant other and they shared some things with me that I thought was interesting. What do you think that perspective is? And just begin to engage that, because that shows that you have some level of investment and interest in them by talking to people that are important to them who may have some insight into what they're experiencing. So again, that's something important. Well, we're screening for and detecting for co-occurring disorders, that we can use some of those assessment instruments or what have you. Some of those you can do even before that person gets in front of you. You can have their pre-forms that they can answer questions to, and sometimes individuals won't answer those questions because they're sometimes sensitive. And then when you get the document, you can at least talk through that and try to help them understand what's going on. What's the severity of the substance use disorder or the severity of the psychiatric disorder? And again, we're trying to figure out all of that through that process, and it often takes time to get to that particular point. And then I think that I know in certain settings, depending on where you work, in order to get a certain level of care, you have to have a certain diagnosis. And that in itself, we should be driven by the presentation. And I think that for those who may only provide a certain level of service, then you want to have relationship with other providers who may be able to provide those adjunct services or higher level or lower level services, and to coordinate with them to make sure this individual gets the right level of intervention. And so we're thinking about that as we go forward. What's the level of intervention that's needed in order to help this person get through the severity of what they are presenting, whether psychiatric or substance disorder? So yeah, we as clinicians, we know a lot about programs in our community. Now what happens when we're the only program in our community? And there are some communities where we are the only program. And that's when we have to be very, very creative and with our treatment planning to really be able to address the needs that we have, seek consultation or some other information to really help support that person as they're in our doors. Determined diagnosis, I talked about that earlier, and I put an asterisk there because we don't want to get hung up and caught up on the diagnosis, but we still have to take it into consideration in the ballpark to know where to start and begin the process. If there's any disability or any kind of functional impairment, that we need to take into consideration. A number of persons that with long-term substance use disorder or long-term psychiatric disorders may have a level of disability. Does that disability impact their ability to engage in treatment, the type of treatment that they can engage in? We're taking that into consideration as well. Strengths and supports, cultural needs, supports, et cetera, et cetera. And once we have all of that, and we're taking that into consideration, now we're working on the treatment plan. Okay, and so as you see, this is not a simple process. And I think that, you know, if nothing else, we are recognizing that, okay, this takes a little bit longer to adequately engage and gather information around gather information to best support this individual. Okay. Questions, comments? I know I've been doing a lot of talking. I'll stop and engage in if there are any questions I can address at this point. Anybody have any questions, thoughts, comments, ideas? All right. Good stuff. All right, so integrated treatment, still talking about integrated treatment, and we are looking at and I talked earlier about the sequential and the parallel treatment, but as we think about integrating treatment, we're talking about mental health and substance treatment are evaluated and addressed same team, same location, same time. Okay, this is where we're trying to get to. And I know some of our programs aren't there. And so whether you're the leader or talk to your leadership about how you can best address the needs of your population. And I think that, you know, we probably all can agree that the persons that walk through our doors aren't just, you know, they don't just have one issue and one problem. And so I think we want to be able to address that. So the treatment should target the needs of those individuals. And we want to integrate it not only in terms of just at the clinical level, but organization. The organization as a whole, that becomes a part of the philosophical approach, that becomes a part of the policy, that becomes a part of the process. Now, while I recognize that some of that is challenged because of maybe how our facilities are licensed, how we're licensed, how our accreditations and a number of other things can be a challenge for us as we begin to carry it out. But ideally, same team, same location, same time, we want to align those things up. And so, again, I've talked about some of this already in terms of integrated treatment. The integrated treatment, dual disorder treatment is an IDDT, which is an evidence-based model for treating persons with co-occurring disorders. And it's a very comprehensive treatment. And one of the things about IDDT is that it allows for individuals to somewhat pace themselves in treatment. And I talked about motivation interviewing. The way that IDDT, it's about meeting the individual where they are. And so it has, you know, what we call stage interventions, and I'll mention that to you in a minute, assertive outreach. And typically in our traditional substance use programs, IDDT is not the most ideal. The way that we see IDDT implemented is best in the confines of an ACT team, assertive community treatment team, because you're doing assertive outreach, you're doing things in the community, and individuals are engaged. And for anyone who's ever worked with an ACT team, you know, these are probably the individuals who are at most risk for hospitalization, at most risk for suicide, at most risk for some of that. And so the way the service is developed and set up is that you're doing a lot of these non-traditional kinds of things, assertive outreach, meeting people where they are, trying to engage them along the way. And so one of the pieces that go along with that in the stage-wise treatment, as you see the stages of change, as well as engagement and what you do at each one of those levels. And so the way that IDDT works is that individuals who are not at the action stage, or they're at the pre-contemplation stage, our efforts and our interventions are very different than they would be at an action stage. And that's how we begin to move people along where they are. And as you know, people today, they may say, hey, I need some help, I want to get it done. But then on the flip side, they come back next week and say, I want to continue to do what I'm doing. So, but anyway, that's just one that I put there. So I'm not gonna run through these. I put the evidence-based interventions in there, talk about what those are. You can look at those on your own. At the end of your presentation, there are some recommendations for programmatic pieces. There's some information in your programs around medication, recommended some common list of medications that may be used for psychiatric disorders. And I put that out there because as clinicians, if someone is using a certain substance and a certain medication, you want to have some knowledge around that medication, how it should be taken, what it's taken for, what are some of the side effects of the medication, because sometimes the side effects can be uncomfortable and the person is saying, well, I don't like the way it makes me feel, so they stop taking it and they start using. Sometimes the side effects are because the dosage is too high. So that's where we need nurses and physicians that we can connect with and collaborate with as we hear some of the symptoms that a person may be experiencing and talking about along the way. So going back to Sharon, and we talked about, seen her, had some ideas about it. Now that as you think about what we've talked about so far, and I'm getting ready to close, we're winding down, and we're going to take any questions that we may have from our virtual team as well as those in the room. Now thinking about Sharon, what would you do with her now? Would you do anything different? Or how would you approach Sharon? What would you do with her? Based on what we've talked about earlier, what we've gleaned and learned and talked about so far. What would you do with Sharon? Anyone want to share? Y'all just ready to go. Yes, ma'am.
I would engage Sharon in a discussion about what happened to her.
Okay.
About what happened to her,
Mhm.
and encourage her to be candid. And I would be looking at depression and her substance use secondary. I would be wondering why she was drinking as much as she was drinking. So that would be, her substance use would be secondary to her depression, assessment for depression.
Okay, so trauma-informed thinking, what happened to you versus what's wrong with you, and getting that history, that information, and addressing the depression, the alcohol. Remember that they could be co-occurring. And we want to, as best we can, address them simultaneously. And sometimes we don't always know what's causing what. Because she had some mood disturbance in the hospital in terms of having her child, we may think that there may be a history more really depression. Father had issue with alcohol. We know alcohol causes depression. So that's that complicated presentation. So we have the symptoms in front of us, so we're gonna treat the symptoms of depression. I agree. What we don't know yet with her is whether the alcohol is causing the depression or whether, and it's probably, as we said, exacerbating the symptoms, but what was happening? Was the alcohol causing, or was she dealing with depression and she started drinking? But either way, we have that presentation. Yes, ma'am. I'll repeat your question. Go ahead.
I think my first comment to share would be, what brought her here today? What did she see that she felt like she needed to come see me? And what maybe was happening in her life that directed her toward me to provide a certain service.
Mm-hmm. She says, I just feel bad. I don't want to feel this way anymore.
So then I would say, well, tell me what you think could happen that would make you feel better. The things that you could do that could make you feel better. And that's so that I can empower her and make it more person-centered. And then I would say, well, let's gather some information to see how I can assist you today to help you maybe feel better about who you are.
Good. That engagement is very important. A lot of times, what we have traditionally done in treatment is we told the client what they need to do and what they're gonna do. And they have no buy-in. And so if you don't see Sharon next week for her scheduled appointment and you trying to figure out why, it's because no one asked her what she wanted. You know, tell me what do you think would be helpful? And sometimes they don't know. They have no clue. I don't know. That's why I came to see you. But at least you give them an opportunity to talk about, well, how did you think you got to this particular point in life? And so those kind of things. So again, what my hope is that we're starting to think differently, begin to think differently around some of these complexities that we're presented with on a day-to-day basis. And I think that, you know, again, I talked about the medication. There's some additional information in your handouts in terms of what some of the core competencies that are recommended for teams, for your staff as you begin to move forward, how should supervise, programming, et cetera. And then one of the things that I'll mention this real quick is that we as programs, and particularly for those of you who are primary substance use programs, mental health programs, we have to begin to look at outcomes and track outcomes. That's how we can find additional supports to do what we're doing when it works in that way. So that's something to think about. So it's been real. I appreciate you all for entertaining me this morning, and this is my contact information if you have further questions, but the information is out there for you. But I wanted to revisit this topic so that we can begin to look differently at the populations that we're serving. None of this is new. It's not anything new. It's just we're revisiting it. And I want to encourage you all, particularly for those of you who have gotten stuck and get stuck in a number of different ways, but we have to expand our knowledge, expand our information. The more informed we are, as I always say, we put more tools in our toolbox. The more tools we have in our toolbox, the better we can address and meet the needs of those persons that we're working with, okay? All right, thank you very much for your time.
For those of our virtual friends who asked the questions, our presenter will be able to go back and check in those and Kuba and be able to respond as well. And you can reach out directly for more information as well. Turn it over to Amy to kind of close us out.
Hey friends, thank you so much for joining. This was my last one, and you guys made it super awesome. We appreciate you guys being here. Thank you so much, Dr. Hargett. We really appreciate you. Registration for spring will open in January. We're back in Asheville, which is super exciting. The snacks are still out. Please take as much as you want for the road to eat, to go on stuff. I won't tell anyone. And if you need your sheet stamped, there's a couple people in here, but a ton of people at registration, so we can get you home quickly. Thank you guys so much.